Good afternoon. Welcome to today's EWOC webinar, the Red Series. Let me welcome everyone here in the panelists and also all the speakers. Good afternoon, everyone. So today we're gonna do a webinar to understand the basis of current and the best practice in ACS patients. So without further ado, I would like to ask the admin to please play the CV of all the faculties today. Shall we start with this first speaker, please? Can you upload the CV? Okay. For the first speaker, let me introduce my very good senior colleague and mentor, Dr. Antonia Lukito. She's the head of cardiovascular department of Pelita Harapan University and Heart Center Siloam Hospital Lipo Village, and she holds a very multiple position in the society. She graduated from Erlangga University for her medical degree, and then she underwent her training in cardiology in Indonesian University, and then she earned her PhD in 2012 in Hasanuddin University. Today, Dr. Antonia will discuss about the dynamics of human coronary arterial motion and its potential role in the coronary atherogenesis. Without further ado, Dr. Antonia, please proceed and you may share your screen. Thank you.
Thank you, Dr. Indah, for the introduction. Apologize for my host sound voice. Okay. So my topic today is about the dynamic of human coronary arterial motion and its potential role in coronary atherogenesis. As we know, stent-related adverse events continue to accrue after the first year of a non-plateauing rate at 2 to 3% a year, with no difference between second-generation DES, first-generation DES, and BMS. Bioabsorbable scaffolds had failed at improving short or long-term outcomes compared to the DES, driven by poor acute performance and loss of long-term vessel dynamic support. What we don't aware is stenting actually inhibit vessel dynamic compliance by altering radial, rotational, and angulation motion and causing vessel rigidity and stent artery compliance mismatch. The uncaging mechanistic concept by restores normal vessel pulsatility by preserving the systole and diastole of the vessel, and also restore the normal vasomotion. The uncaging concept will allow the artery to dilate in response to nitro and to the heart's need for more oxygen. Moreover, by restore radial radial compliance will minimize inflammation and reduce compliance mismatch, reduce biomechanical stress, and improve clinical outcome eventually. Movement like bending, twisting, and pulsation of a stented artery add additional stress on the stent and the vessel wall. Uncaging concept may reduce vessel and implant stress. Bioabductor also restore vessel rotation and may reduce stent fracture and adverse event rate, and also allow vessel to return toward baseline angulation. Important to note that vessel straightening is a predictor of MACE. Hence, Dynamics Bioabductor is designed to deliver sustained superior clinical outcome by restoring normal fascial function, by restore positive adaptive remodeling, restore vessel function, and restore vessel dynamic compliance. After learn about the mechanistic study of bioadaptor, now how about the bioabductor randomized clinical trial, which has presented at EuroPCR of less than 2 months ago by Shinsei Shigeru Saito. A dynamics bioadapter has copolymer as top coat containing sirolimus designed to elute over 3 months, and bioabsorbable polymer base as a base coat dissolves over 6 months to unlock the 3 uncaging elements in its ring, and unlocked helical strands continue to provide the dynamic of scaffolding support. There is 445 patients enrolled to the RCT and grouping in 1:1 ratio between Dynamics and Resolute Onyx DS. The primary endpoint of target lesion failure at 12 months and clinical follow-up up to 5 years, while the secondary endpoint are the imaging by QCA or IFS or OCT. When we look at the patient baseline and angiographic characteristic, which actually mimicking our regular daily proportion of patient. The primary endpoint of target lesion failure non-inferiority was met significantly. As we see, the blue bar is representing dynamics, and the gray bar is representing the resolute onyx. Yeah, we see that target lesion failure, cardiovascular death, and definite or probable stent thrombosis is better in dynamic arm. But the clinical driven TLR, there is a star there. So one TLR patient violated the exclusion criteria of in-stent restenosis. So the bioadapter was implanted in the lesion previously treated with a bioresorbable scaffold. And the second TLR patient also violated the exclusion criteria of severely calcified lesion, the lesion that required 4 balloon pre-dilations. And then the secondary endpoints were the pulsatility and compliance at 12 months were also met, as the return of compliance only found in dynamics arm. Furthermore, the increase in blood flow, lower late lumen loss, lower percentage of diameter stenosis, and lower neo-intima hyperplasia volume are better in dynamics arm than the resolute onyx arm. Therefore, the conclusion of the RCT is primary endpoint of non-inferiority was met. That is 1.8% versus 2.8% at 12 months, with significantly. Acute procedural performance was similar to DES, and dynamics bioadapter demonstrated superior across key secondary imaging endpoints at 12 months, with by restoration of in-device pulsatility with dynamics, significant lower late lumen loss and percentage of diameter stenosis, and also significantly lower neo-intimal hyperplasia volume and percentage of neo-intimal obstruction. So that RCT also revealed the novel finding that after stenting at 12 months, there are changes of plaque volume behind the device. So we may appreciate the resolute onyx has a little bit higher percentage change versus the dynamics. So in that case, blood volume changes behind the device in lipid containing lesion is better in dynamics. So the dynamics with the uncaging concept will working until at 12 months and above. So the conclusion of the RCT dynamics is not non-inferior to DES target lesion failure with favorably low event rate. dynamics demonstrated superior restoration of vessel motion and function, and plaque stabilization and regression in dynamics bioadapter compared to plaque volume increase in DES may point to synergistic effect between lipid-lowering medication and restore vessel motion and function. If we still have time, I will share 3 cases experience in Indonesia, which is bioadapter implanted in a female who declined cabbage and in anterior STEMI, and also in heavy calcification of LED. Please, Dr. Indah, remind me if my time is out.
Sure, go ahead, Dr. Antonia. And can you put up the slideshow for this slide?
Oh, I forget.
Okay.
Sorry about that.
Thank you.
So the first case, Mrs. DS, 55 years old with strong family history. So the whole family is my patient, including the grandfather, the father, and the sibling. So this female without any significant symptom, but come out with 3 vessel disease with multiple lesions, and she is declined cabbage. So I did the PCI for the not 3 vessel actually, because the LCX is not so dominant. So I put the S in proximal LED and bioadapter at distal RCA, and also the other dynamics at proximal to mid RCA. But unfortunately, after post-dilation with non-compliant balloon up to 20 ATM, because we are catching the well opposed with stent boost, everything. So after well expanded with stent boost, unfortunately that dissection was noted at proximal stent 8, was also we implant another DS, short DS at the ostial proximal RCA overlapping to dynamics. But this procedure was successfully. Also the clinical outcome in about four months, the patient has no any complaint, and the ECG is very good. And this second case is in anterior STEMI in a male 61 years old. We disclosed 2 vessel disease with culprit lesion of total occluded with thrombus burden at mid LAD. The RCA is 75 lesion at mid to distal. So we did the thrombectomy in LAD and then put the dynamics at mid LAD 3.0 15 by 15 millimeter overlapping to sincero because of the budget problem of the patient. And another this resolute onyx at mid distal RCA. Maybe that's good with variation of the stent and pair of the so we compare it. We can compare later. This is the result. This is the occluded, and then after PCI back to TME3. So this is the follow-up. The risk factor of the patient is only pre-diabetic and dyslipidemia. Echo 1 month later show hypokinetic of only the apicoceptal and preserved LV engine fraction, and also preserved diastolic function, and also the RV function. The NT-proBNP in the first month 352 down to 124 at the second month, and now the patient can walking 3 kilometers in 30 minutes every day. And this is the last case. I like to try bioadapter in heavy calcified patient. So this is Mr. G, 57 years old with positive treadmill test on regular medical checkup. So actually he has multiple cardiovascular risk factor like hypertension, like diabetes, dyslipidemia, also family story of heart disease. So the angio revealed to have a calcified vessel. LCX is non-dominant. And in this lesion, I'm using the diamond back orbital atherectomy system, and also after that scoring balloon and with IVUS. So the is the lesion, the target lesion. This is heavily calcified, and then this is the result after all of this effort. And then this is another view. This is the lesion, and after this, the lesion look nice. I first show this is maximum. I cannot do more. Area was exactly at MSA. Minimal stent area was exactly at 5.4, the minimal requirement. And that's all for the cases. Thank you, everybody. I will stop here.
Okay, thank you, Dr. Antonia, for kicking off our webinar with that nice talk and a sample of a few cases. Now, before we continue to the next speaker, let me just address the audience that today we're going to have 3 speakers, and one of them are Dr. Deborah, coming from Singapore, and we are going to conduct the webinar in English, but feel free to ask your question in the chat box and the Q&A box in Indonesia or in English. That will be fine. And we'll address your question at the end of the sessions with all the panelists, Dr. Yusra, Dr. Lely, Dr. Ati, and Dr. Elen. All right, so let's move on to the next speaker. Let me introduce my good friend, Dr. Deborah Lee. She's coming from Singapore. She's a cardiology consultant from Tock Seng Hospital, Singapore. She's been practicing for more than 10 years at the areas of expertise, invasive cardiac, non-invasive cardiac, and general cardiology. I know that Tock Seng Hospital have a lot of cases, especially STEMI cases and all the complex cases that you are so passionate about. So looking forward to learn from you, Deborah, this afternoon. So without further ado again, I'll let you take away the webinar.
Okay, thank you, Indah. And I just want to thank Dr. Yusra, the chairperson of the Women Cardiology Force, and also all the speakers and panelists and the audience for inviting me to give this talk. So basically, I'll be addressing today on treating STEMI patients, sharing the challenges of our conventional DES that we have now, and also our experience in Tock Seng Hospital. So my overview of the talk is Dr. Antonia has given a very excellent overview of the latest stent, the bioadapter that we have. And basically, I'm here to just give this talk as an overview of why do we need newer generation stents in STEMI patients. So let me walk you through the journey of the stent so far. Even before the drug-eluting stents came about, going back to balloon angioplasty, we all know Andres Grunzek, who is the first to develop the balloon angioplasty in 1977, but not many of you might be familiar with Adolf Bachmann. He was the first patient to have undergone this balloon angioplasty. So this was the first day this was how Anders developed the PTCA balloon over the kitchen table with a glass of wine. It was initially this 20 millimeter balloon with a short fixed wire at the tip that you had to shake it to deflect it off the plaque to deliver. So the first angioplasty was performed in the proximal LAD. And when they did a relook angiogram up to 20 years later, it was still patent. And this was the patient in 1977, and he was still alive in 2015. So with this balloon angioplasty setting in, there was an initial problem of acute closure. So during the PTCA era, surgeons had to be on standby. And basically this led to development of bare metal stent. And maybe Dr. Antonia will remember there was a Cook GR2 and Palmachets, and basically these stents were rudimentary. As you can see, it had poor surface area coverage, poor radial force, and there was gap in it. And nonetheless, it worked in solving the problem of acute closure. But it led to another problem, which was basically restenosis. So there was excessive neointimal hypoplastic response due to the injury to the media of the vessel, and half the patients were coming back usually within 6 to 9 months with recurrent symptoms. So this led on to the third transformative era, which was the drug-eluting stent era. And the first generation was born with 3 components: the drug, the polymer, and the stent. And basically, the first generation were the Cypher and the Texas, and the stent consisted of a thick stainless steel material. The polymer was biocompatible but somewhat pro-inflammatory. The drug that was used was either paclitaxel or sirolimus. So it underwent a series of randomized trial, which was published first in NEJM in 2006, basically comparing the Cypher stent to bare metal stent for off-label primary PCI, so implantation. So what it showed, it was basically significant up to 50% reduction in terms of the endpoint, which was the target vessel failure. And when they did the other trial, the PASSION trial for paclitaxel eluting stent, it also showed a significant reduction in MACE. So putting all these studies and many others, the meta-analysis of first-generation DES and STEMI seemed to be superior as compared to BMS. And we were convinced, and this was 2007, and everyone was convinced that first DES was the best-in-class treatment for primary PCI, and things were good. Things looked good within 1 year. But from 1 year onwards, we seem to be seeing a higher rate of definite probable rate of stent thrombosis, as you can see. So why is this things happening? So basically, there are several factors that's accounting to this. And firstly, it was delayed endothelialization. And you can see here in the DES group, even at 1 year and 2 years, 3 years, there was still delayed endothelialization in the DES group as compared to the bare metal stent. And secondly, it was not just about delayed poor healing, it was also about the type of lesions that we're treating. So in comparison with a stable plaque where there was fibrous tissue, stent implantation showed good healing process, but in AMI lesions, which the lesions were unstable, which consists of necrotic core, lipidic plaque, there was seemed to have delayed healing process. So you can see incomplete healing in up to 50% as compared to 9% of stable patients. So this led on to further development of our DES technology, the second generation stent, where the stent was of thinner strut, and it was made of cobalt chromium, which was more malleable but inherently strong. The polymer they used were fluorinated copolymer, which had some thromboresistant properties. The drug that was used were basically the limus analogs because they had wider toxic therapeutic ratio as compared to the paclitaxel. So this is basically the animal model showing even more even endothelization in the second generation stent. And in terms of intravascular imaging, you can see in comparison with the early DES, the new DES had a very even arterial healing as compared to early DES, where there was some irregularities like cauliflower appearance with protruding stent struts. So this led on to in 2017, where ESC published the guidelines giving a 1A indication for newer generation DES over BMS. And what led to this were the trials as follows. The examination trial, which was basically published in Lancet in 2012, they look at 1,500 patients comparing the second generation everolimus stent versus the BMS in treatment for primary PCI for STEMI patients. So these patients were followed up. Initially, at first year, it seemed to be having a superior outcome, but not statistically significant. But as over the years, moving up to 5 years and 10 years, the curves seem to have separated and showing superiority. And not only in examination trial, but this was also confirmed in comfortable trial where they compared BMS to the biolimus eluting stent. And this was also confirmed by the pool analysis where the primary endpoint was favorable for drug eluting stent, mainly driven by reduced reinfarctions and repeat revascularization. So are we in a perfect world? No, in fact, as what Dr. Antonia mentioned earlier, there is still, in the best of the stents, cobalt chromium stents, there's still adverse events occurring after first year at a rate of approximately 2 to 3% per year. And this may be attributed to inflammatory response, hypersensitivity reaction to the drug or polymer. And sometimes when we deliver stent across tortuous calcified arteries, there can be polymer damage causing irregularities, which can be a nidus for thrombus. And mechanical issues still occur, such as strut fracture, longitudinal stent deformation. And importantly to say, very late issues with permanent metallic implant, which basically cause vessel straightening and loss of cyclic strain, loss of vasomotion, and adaptive vascular remodeling, which was also mentioned by Greg Stone in JAMA 2019. So this led on to further development of our stent, the BioSTEMI trial, where they looked at Osiro, which had thinner strut, 60 micron, and the polymer they used was a bioresorbable polymer. And this was compared to the science group, which was 80 micron thickness and a durable polymer. So when they did a 1-to-1 randomization in this STEMI patients and looked at the endpoint of target lesion failure, at 1 year, it showed superiority, and it was also seen at 2 years. Not only was this stent compared, this was the first randomized trial that was comparing head-to-head second-generation stent. And there's also this polymer-free stent, which I think all of you have heard, a BioFreedom stent. What's so special about this? They don't call themselves drug-eluting. They call themselves drug-coated because it's polymer-free. And the advantage of being polymer-free is you avoid any possible polymer-related inflammatory adverse effects. At the same time, the BioLimus drug is more lipophilic, 10 times more lipophilic than other limus drugs. So it gets rapid transfer to the vessel wall, and then the drug self-elutes over time. So because of this rapid transfer, it behaves more like bare metal stent, so it's good fit for short DAPT. So they studied this patient in high-risk, high bleeding risk patients with 1 month DAPT, and which showed basically significantly safer and more effective than the BMS. And the safety benefit was mainly driven by the ACS subgroups. So we also did this BioFreedom study in our patients, followed up for 2 years. We had 164 STEMI patients then, and the stent thrombosis rate was 0.6%, which is comparable to other second-generation stents reported. So lastly, not to mention this Dynamax bioadapter. So it is basically the first metallic implant that adapt to vessel physiology. So what's so unique about this, like what Dr. Antonia mentioned, is basically the uncaging elements. So this is a cobalt chromium, 71 microns. And after the drug elutes and polymer resorb, the uncaging elements, the vessel uncages. And as mentioned earlier, it restores compliance. There's positive adaptive remodeling. And it restores vessel angulation. And I think Dr. Antonia also mentioned about plaque regression, which was recently reported in the EuroPCR. However, there is no clinical data in PERMI-PCI. So we also look at this group of patients between January to October 2021. We recruited 20 patients who came in with STEMI to our hospital. And what we looked at was the major adverse cardiac events and the TLR at 30 days and followed them up for 6 months. So this was presented at TCCAP last year, where at 30 days, there was no death and no other reported events. And as you can see here, the mean age was 56, mainly inferior anterior STEMI. Intracoronary imaging was used in more than half the cases, and most of our vessels were thrombus-laden, being a STEMI, and 3 cases required penumbra. And as you can see, at 30 days, 48 patients were followed up. There were no events. And at 6 months, we had 38 patients, and there were no significant events as well. And so far, at 1 year follow-up, there were 25 patients who have completed we don't see any events. So let me just share some of the cases that we have. We had a guy with 61-year-old with anterior MI. As you can see, it was IVUS guided, and the stent delivery was like any conventional DES. And without body wire, without guide liner, the delivery was good, of a 38 mm length. And this was our final result. And then second case, we have a 67-year-old inferior MI, flow was restored, and then we went on an intravascular ultrasound-guided PCI. And as you can see here, with the IL guide deeply seated, we could deliver this 38 mm stent. And basically, this was the final result. And we did a restudy for this patient at 7 months and still looked excellent. So in terms of stent visibility, it is visible like any other stents, conventional drug-eluting stents we have. And basically, in conclusion, the preliminary experience of this Dynamics usage is shown to be safe and visible in primary PCI so far. And there was no reported MACE at 30 days, 6 months, and for 25 patients, we have at 1 year outcome. And basically, of course, longer follow-up is needed in larger cohort of patients to confirm the long-term safety and efficacy. So in summary, use of newer generation DES appears not only more effective, but safer than BMS in STEMI treatment. And there is available evidence to date to suggest that the difference in stent platform may play an important role. And this evolving new stent platforms like Dynamics Bioadapter, and with this uncaging concept, this may potentially address this 2 to 3% of adverse event rate yearly that we still have, thus leading to improving long-term patient outcomes. With that, I just want to thank you.
Okay. Thank you so much, Deborah, for that very clear-cut presentation. I have so many questions that I will ask you later on after this next speaker, and then we'll have the discussion session. Okay, so the next speaker we'll have, because we believe that we treat patients, we don't think only about how to treat them interventionally, but also how to monitor, how to image properly, and how to follow up in the long-term run. So we have here now Dr. Astri Astuti. She's a imaging consultant from Hasan Sadikin Hospital in Pajajaran University in Bandung. She trained in Harapan Kita for her fellowship in imaging and finishing her training in Royal Brompton Hospital, London. Dr. Astri will talk today about the cardiac imaging and long-term outcomes after stent implantation. So after implanting a stent, we'll see what she has to talk about. Thank you. Go ahead, Dr. Astri.
Thank you very much, Dr. Indah, for the kind introduction. I will share my screen first. All right. Good afternoon, Professor and everyone, my dear colleague. Thank you very much for the committee for inviting me, so I can also learn from the prominent women interventionists and share some perspective from cardiac imaging. And today I would like to discuss about cardiac imaging and long-term outcomes after stent implantation. After implantation, either in acute or setting or chronic setting, we can evaluate the stent patency by functional or anatomical evaluation. And mainly in stent restenosis is usually the focus of the study in most non-invasive imaging and in the patient with coronary stents, because it's often asymptomatic despite hemodynamic significance of the stenosis. On the other hand, in stent thrombosis typically goes along with chest pain and requires acute therapy. And stent patency evaluation might be needed in several kinds of patients as surveillance and acute coronary syndrome patient which underwent primary PCI may already have infarction or microvascular obstruction. And there are also studies that shows residual ischemia even in successful revascularization. So we will discuss about how cardiac imaging helps clinician for coronary evaluation after stenting and also determine the prognostic risk stratification and also when is the best timing for modality evaluation. So let us start with the CT. Based on the appropriateness criteria from AHA in 2010, for the post-revascularization evaluation, first we need to consider whether there is any symptom or not. If the patient has chest pain, then we should evaluate stent by CT if the stent diameter is more than 3 millimeters or more. If less than that, it's considered inappropriate to evaluate with CT. And on the other hand, in asymptomatic patient, then we should stratify whether it was a left main stenting or not. Then if yes, then it's a good to have CT evaluation. And if not, and it's already 2 years after stent implantation, and also the diameter of the stent is more than 3 millimeters, then it might be appropriate for us to conduct a CT. 10 years later, in 2021, AHA, ACCT, and also SCMR guidelines gave a class 2A recommendation for evaluating symptomatic patient after revascularization. And CT is still recommended if the patient had more than 3 millimeter diameter of stent. And to improve accuracy of stent imaging, it is better to have a strict heart rate control and preferably less than 60 beats per minute. And in latest SCCT consensus, they also agree in addition, and additionally, it may be appropriate to perform CT in symptomatic patient with those known to have a thin stent struts less than 100 micrometer, and it should be in a proximal or non-bifurcation lesion. In analyzing stent by CT, there are several factors that will affect stent appearance. The visualization will be depend on stent size, diameter, type, and also the procedure. And currently, CT has good spatial resolution and can produce a good image for a stent which more than 3 millimeters. And in terms of the stent type, stent design and strut thickness will also affect the analysis and more likely to cause non-visualized stent lumen in a thicker struts. In the upper image, there is 2 Taxus stents with more than 100 micrometer strut thickness, this one, and a science fee stent with less than 100 micro thickness, and there's notably more blooming with the thicker struts, and a relatively low density metal such as magnesium or cobalt chromium will appear to be more less artifact. And the example is this number 10. It is example of cobalt chromate stent. In a high atomic numbers metal such as gold or stainless steel, they usually have more artifacts. And this is an example of various type of stent appearance. And also additionally, in terms of procedure, a more complex procedure, for example, bifurcation and also overlapping stent, there are multiple layers of metal and will cause more blooming artifact and thereby limiting the visibility of stent lumen. Oh, sorry. This is an example of a patent stent with size 3 millimeter. And if there is an occlusion, then we can see neoproliferation of intima that's seen as a dark area inside the lumen. CT can be a gatekeeper compared to invasive angio in patient after PCI. And in this study, they did a follow-up CT at 9 months after PCI in around 1,700 patients. And after follow-up for a median 5 years, CT showed that can reduce the target lesion revascularization compared to invasive coronary angio. All right. Now let's move on to the cardiac magnetic resonance role in stented patients. CMR can help us to determine the risk of MACE, such as cardiac death or heart failure, by evaluating late gadolinium enhancement and microvascular obstruction in post-primary PCI patient, and also to look for inducible ischemia in any chest pain after revasc. In STEMI patient after revasc, CMR can be used to evaluate damage and its extension, and should be done early within 3 to 12 days, and mostly within a week. And in this phase, we could evaluate regional wall motion abnormality, infarct size, area at risk or edema, myocardial sulfation, and also microvascular obstruction. And in the late phase, around 4 to 6 weeks to up to 3 to 6 months, in this phase, the inflammation due to ischemia usually already resolved, and we can analyze the final infarct size and also the inducible ischemia if any new symptoms noted. In reperfused STEMI, the early evaluation by CMR can show the burden of area at risk is the area that prompts to become infarction. Area at risk is a territory that's supplied by the culprit artery and consists of reversible injured myocardium, or we call a salvage myocardium, and also infarcted one. In acute infarct myocardium, it will appear as subendocardial enhancement, and sometimes with microvascular obstruction that appears as a hypointense area within the LGE. The salvage myocardium will appear as edema area, and in CMR, it can be detected by T2 STIRS, T2 MAP, late or late gadolinium enhancement. The LGE extension in this phase not represent the final infarcted area of myocardium. And MVO, or microvascular obstruction, that usually caused by no reflow phenomenon or intramural hematome, will appear in almost all sequences, especially in early and late gadolinium enhancement. We should pay more attention with patients with microvascular obstruction because in this study, there is of 500 patients undergoing primary PCI for STEMI, cardiac MRI was conducted in around 400 patients during the index hospitalization, and almost 70% of them had MVO. And the Kaplan-Meier curve for the cumulative occurrence of MACE and the incidence of deaths is also increased in patients with MVO. LGE existence and its extent is associated with higher incidence of MACE as well. And the major finding of this study is that LGE quantification very early during STEMI will predict a late heart failure and adverse events. Also, during the hyperacute phase of STEMI, the LGE volume more than 23% is strongly associated with LV function change in 5 months following STEMI. CMR is also an excellent tool to monitor myocardial function after stent, and this is an example of non-viable and viable anterior wall segments with wall motion abnormalities. And the upper image, we can see that the LGE appears more than 50% of transmurality and even almost near transmural. And after revas in 2 months, there's no significant improvement in volume and function. And the bottom image, where the subendocardial enhancement is around 25%, and it's indicated that it's a viable myocardium. So we can see in the next 2 months, we can see that there is improvement in LV function. So how do the guidelines say about stress test position after revas? In 2021, AHA, ACCT, and ACMR guideline gave class 1 recommendation for evaluating symptomatic patient after revas using stress tests. And while in 2019, the ESCCCS guideline said that non-invasive test for ischemia is suggested in high clinical likelihood of patient. Other than that, stress test is also useful to objectify the symptoms or evaluate for microvascular disease in revascularized patient. The recommendation was also based on a strategies trial, which compare anatomic evaluation by CT and functional strategy using stress CMR in symptomatic patient after revasc. After 2 years of follow-up, the investigator reported that a stress CMR strategy was associated with a lower rate of invasive angio, revascularization, and also adverse cardiac events. There's another study that shows residual ischemia at 5 to 6 months after revas, and it's shown in CMR stress tests. They have 24% of PCI patient that still has residual ischemia, while it wasn't detected by invasive angio. So it might be underestimated by the invasive angio to evaluate the residual ischemia. There is a sub-study of COURAGE trial where there was 105 patients underwent serial MPI or myocardial perfusion evaluation by SPEC within 5 years after PCI. then showed a reduction in ischemic region, and also they shows that reduction of more than 5% of ischemic burden will significantly reduce the MACE and cardiac death. So there are several risk factors that increase the risk of in-stent restenosis and also thrombosis, such as left main stenting and then atherectomy device, or using of long stent more than 60 millimeters. This condition might increase the awareness of clinician to do more intense follow-up in this kind of patient. In-stent restenosis is caused by various mechanisms, including biological, mechanical, and also technical factors. And the neointimal tissue proliferation is composed of vascular smooth muscle cell and extracellular matrix in a diffuse pattern. And the peak of presentation will occur around 6 months after implantation and as early as 3 months. So in terms of timing, currently no established guideline for best timing decision in surveillance study after stent, but the best timing probably will be based on individual basis, whether there is any new chest pain symptoms, any high-risk thrombotic condition, or complication during PCI procedure. So as conclusion, cardiac imaging has a multiple role in stented coronary, either anatomical or functional evaluation. And CTCA is recommended for stented coronary anatomy evaluation, while CMR in acute setting can evaluate area at risk and final infarction size, which are markers for MACE and ventricular remodeling. And stress tests are essential in symptomatic stented revascularized patient, and no exact appropriate timing evaluation after stenting, and it will be based on symptoms and individual setting. Thank you very much for your attention.
Thank you so much, Dr. Astri, for your nice presentation. So I would like to invite all the faculty speakers and all the panelists to open their camera. Now we're going to enter the discussion session. So today we've talked about the latest technology in terms of how to intervene coronary cases, especially in the settings of STEMI, right? So, but today we're gonna talk a little bit deeper about this latest technology, about the bioadapter technology. I think I have a question myself, but I would like to ask all the panelists first if they have a burning question in mind. So I would like to open the first question for Dr. Yusra, and then Dr. Ati, and then continue to Dr. Lely and Dr. Elen. Go ahead, Dr. Yusra. Dr. Yusra, you're still muted.
Because my connection is poor right now. I'm very interesting with, sorry, can you listen my voice?
Yes, we can hear you clearly.
Okay.
Ask your question away.
Thank you, Dr. Antonia, Dr. Deborah, Dr. Astri for interesting presentation. And we know that bioadapter is the newest generation, yeah. And the benefit like positive adaptive remodeling, restores vessel function, restores vessel dynamic compliance, and it's very interesting. And as we know nowadays, we have problem for interventionists about in-stent restenosis. And as we know that nowadays we use DEB for in-stent restenosis. Maybe I want to ask to Dr. Antonia or maybe Dr. Deborah, what do you think? Which one is superior for ISR, bioadapter or maybe DIB? Because we know bioadapter is the newest generation, and I hope it's very useful for it. And my second question, how about the APT for patient who already given bioadapter? Is it same with the previous generation stent, or maybe we only give 6 months or maybe 3 months? What do you think? Thank you.
Okay, thank you, Dr. Yusra. Maybe Dr. Antonia can tackle the question first, and then Deborah, you can add on later on. Go ahead, Dr. Antonia.
Okay, thank you. We still have no experience about using for the instant restenosis patient, but time will tell. As I think the elixir will start multi-center clinical registry, also in real-world registry. Yeah, maybe time will tell. I think maybe in some cases we will use a bioadapter instead of DEB. And then, if I may, for the second question, I forget the question. But
how about the DAP?
Oh yeah.
Previous generation.
Yeah. Okay. Because the drug, the limus will gone in 3 months, but the polymer only will be gone in 3 months. So I think maybe Dr. Deborah later can give opinion too. I think the DAPT would be 6 months, and after that we can use single antiplatelet.
Yeah, I also agree with Dr. Antonio, what Dr. Antonio said. And basically, there's still not much evidence in this exciting bioadapter, which, I mean, so far, there's been no stents that was mentioning about restoring vasomotor function. I mean, so far, leaving the vessel uncaged has always been just DCB, and now we have this uncaging element. So I think for ISR, I mean, there's no evidence yet. And, you know, even in the US at the moment, they're treating ISR with just implantation of another stent, you know, because the DCB is not FDA approved at the moment. But I think the plaque regression that Dr. Antonio mentioned in the presentation of the trial is something very exciting, because, you know, the current DES problem that we have is actually neoatherosclerosis. It's not just neointimal hyperplasia. And neoatherosclerosis is like calcified neoathero, and it's so difficult to treat sometimes. And it's so difficult once you implant one layer of stent and you get neoatherosclerosis, is calcified, so you have to use scoring balloons and all that for expansion. So in fact, I mean, if you could imagine a world where, you know, you implant a bioadapter and then there's plaque regression instead of plaque building, I think it might be an exciting field where we will await for further studies to come. And it's actually the plaque, you know, one of the things that create plaque is the stimulus of the foreign body and the rigidity of the vessel. So, I mean, having a bioadapter will be another, you know, create another realm where is there less ISR that develops? I'm not sure. And about the DAPT duration, like what Dr. Antonia mentioned, the drug elutes in 3 months, the polymer in 6 months. So I think it's in the acute phase, acute performance is like any other conventional newer generation drug eluting stent. I think the bioadapter will show its superiority more in the later stage, like after 1 year or so. That's awaiting further trials. Yeah.
Okay. Wow. Okay, that's great. I'm actually really interested in the bioadapter system, and really looking forward to its you know, long-term outcome result. And especially in the various type of lesion, or maybe calcified lesion, will it still works the same because it's stiff arteries? Will it work also for calcified lesion? And whether it works also for bifurcation lesions and so on and so forth. So far, I understand that most of the data is for stable CAD. And not much of them are STEMI patient, actually.
I think Dr. Antonia implanted the stent, the bioadapter in a calcified lesion. Can I just ask your experience about how is it like, deliverability and all that?
I think I have not met any problem in deliverability, because the platform is cobalt chromium, just like another new generation of DES.
Right.
So and I think the bioadapter would be used more and more in STEMI. Why? Because in STEMI, usually vessel is in spasm condition. Yeah. when we do the IFAS after, we only see the spasm patient, even with the nitro on, yeah. But with the bioadapter, which continually giving the positive adaptation, I think the spasm will be overcome by the uncaging concept.
Yeah, but what interesting to me is that whether it actually work in a calcified lesion, because the vessel itself is very stiff already. I mean, the concept of bioadapter being uncaged is that it's gonna make the the rotational motion or the natural movement of the vessel as it is supposedly. But in a calcified lesion, will it still work the same or not? Or will it? Or we just use the the usual DDS. I mean, yeah, that's actually my burning question. But before you answer that, I'll go to Dr. Ati. I think she's also have a very burning question in her mind. Now, Dr. Ati, please go ahead. Do you have any experience with this bioadapter yourself? Thank you.
Yes, thank you, Dr. Indah. Thank you. I really enjoy all your lectures. Yeah, I do have some, not much, but several experience regarding this. That is why one of my question is, how about in your experience that as a Dr. Deborah, same as Dr. Deborah question about the deliverability, but it's already answered by Dr. Antonia. However, in my experience, still doesn't have any much difficulties also. And however, in what I want to ask is there in previous stent, we tend to think about the stent coverage, strut coverage in putting it in one stent. But in this particular stent, we can see that there is uncaging elements after several months. But how is in this kind of stent? Is it really necessary to think about the stent coverage if you want to put like a bigger stent for better coverage in this dynamics bioadapter stent? What do you think? I'm not asking about the data because this quite early if we want to ask about data, but I'm just like curious and asking for your opinion. And I have one other question for Dr. Astri regarding timing. Even though you already said that it's not really strict, but I want to ask your opinion based on your experience as an imaging, because usually we do a staging PCI. So if we want to do like CTO cases after we put stent in the left side, do we have to use? Do you have to put another in the right side if it's in multifaceted disease? For after how many months we can see the progress of our work? Thank you very much.
Maybe Deborah, you want to answer the question, and after that, Astri.
I think in terms of like, I think your question was pertaining to anyway the vessel and uncages and whether it's important to size the stent. Is that correct? Yeah. So I think there's a limit to how much uncaging and the luminal stent gain that you can get. I think the most important thing is making sure there is no gross malapposition. I think is still important. So I don't think the use of intravascular imaging is less important now that you have uncaging vessel, because still, I mean, malapposition, especially in the proximal part of the stent, is actually should not be there for future procedures so that the wire doesn't go behind the stress. So I think it's still important, and we all don't know how much uncaging and how much gain in that stent. It depends on the vessel compliance as well, I think. So I think that I think it doesn't change in that sense. Yeah.
Yes, I agree with Dr. Deborah because the helicoidal strands is using for dynamic support after the link has gone. after engaging, if we put too small diameter of the stent, and after engaging in the bigger vessel than the diameter of the stent, it will some part of the vessel will not supported by the stents.
Okay, Dr. Astri, can you address Dr. Ati's question?
Yes, thank you, Dr. Ati, for the questions. I think in terms of timing, because based on the pathophysiology of neointimal proliferation, mostly started at around 3 months, and the peak will be around 6 months after implantation. So maybe we can, this is just my opinion, maybe we can start from 3 months and 6 months, and other than that, it will be depend on the individual basis. If probably if you have a complication during procedure, or you have a high risk thrombotic case event, for example, it's like longer stent or left main stenting, also in bifurcation stenting, probably you want to evaluate even frequently, more frequent, and that type of patient probably. I think probably that's my opinion.
Maybe
Thank you.
Ellen, do you want to add on for Dr. Astri about what's your comment about that?
Yeah, thank you, Dr. Indah. Now, I just want to share that today I just scanned a patient post PCI with DES February this year. So it's about 4 to 5 months ago. Actually, the patient has 3 vessel disease already implanted by DES stent in the RCA, and the patient with atypical chest pain, but with known long stenosis, diffuse stenosis at LAD. And then I just found that in 5 months, there is the calcification. I thought it was old lesion, but it protrudes to the lumen of stent. So I think there is already neocalcification there, growing up, and then maybe just about 20% stenosis, but it starts up here. What I mean. About the timing, what I mean, I think to do CT is, we come from the symptom first, but not because we use radiation, so not for screening or routinely screening, but comes from the symptoms. And
Okay.
And some factors that you think it may high risk features for ISR.
Okay, thank you, Dr. Ellen. Actually, I have a question for all the imagers here. What do you think about the the resolution? Is it good enough with CT to evaluate this, let's say ISR, or would you? And versus, I would also like to ask all the interventionists here in the panels also, if you have a patient with chest pain, would you rather go with the non-invasive or the invasive? If we have a little bit of discussion, because we want to just ask the around the table here. Let's say, Dr. Lely, would you do CT, or would you like to do CAT instead?
Yeah, perhaps depends on the situation, Dr. Indah, and maybe all of agree with about what chest pain, what scenario. If it's ACS, then send to the cath lab, and then if it's chronic stable angina, and then we have to stratify first the risk factor and so on, and then we have to divide it whether this is more suitable for doing MSCT or send to the cath lab. That's my opinion.
what's the practice actually in Tock, Seng, and Deborah? Let's say patient post PCI 1 year, and then the patient got chest pain. Would you send the patient for CT first, or other imaging modalities, or would you go straight to the cath lab?
I think it depends on the chest pain. I mean, if it's like atypical chest pain with previous stenting, then I think we will still do a stress test or CT. And I mean, we don't have CT FFR at the moment, so I don't know in future if you have the CT FFR, maybe that might be even more valuable. And if it's classical, and also if it was a high risk stenting, like the high risk of restenosis stenting, kind of like left main bifurcation, stents, then yeah, I would proceed with a angiogram straight. So I think the decision differs. I think CT, I guess Dr. Astri might be the best person to comment, but if it's a small stent, it might be difficult to see restenosis unless it's like 3 mm stent or more in diameter. But definitely, if there's a left main stenting with classical symptoms, then yeah, I would be more it would be low threshold to go in and have a look, just cath straight away. Yeah.
Okay, Dr. Astri or Dr. Elen, can you comment on this issue? Would you suggest CT or any? Maybe you would suggest other imaging modalities.
Right. I think it depend on the symptom. If it's typical chest pain, probably you want to objectify the symptom first. You can go with a stress test, and you can see whether the chest pain is related with the ischemia objectively during the stress test. And for CT evaluation after stenting, it's class 2A in chest pain patient after revasc from the 2021 AHA guidelines. So you still can do CT, but you cannot objectify the symptoms with the lesion that you find out during the CT. And probably for evaluation with the CT, at least we need a 3 mm diameter for the stents, so we can visualize the lumen better. But if you have a high resolution CT, like more than 256, like name it 512 detector scanners, then you can also, there's some study and also small cases that shows they can evaluate the lumen as well using, if the diameter of the stent was 2.5, by using the ultra high resolution CT. But if you don't have it, please don't try it. Otherwise, it will be more artifacts in the CT. I think that's my opinion. Probably Dr. Elen has more opinion regarding about it.
Yes, for first revascularization evaluation, I agree with Dr. Deborah. We look, and also Dr. Lely, we look into the clinical setting. Is it acute or chronic or stable? For acute, or if you suspect for acute thrombosis with acute coronary syndrome, you can go to the cath lab. And then for the chronic, functional imaging is better than anatomical testing with CT for now. But the technology of CT is continuing developing, and there is a new technology called that ultra high resolution CT or photon counting CT with a very high doubling spatial resolution until 0.2 millimeters spatial resolution, and also can combine with the dual source CT. So maybe 10 years later, or 15 years later, it will be very good for stent evaluation. Now for the photon counting CT that available now, actually there's one in Indonesia, and it can it makes us possible to do stenosis quantification for the percentage compared with the conventional or general CT scanner. And then, yeah, I think that's all. That's the future of cardiovascular CT.
Okay. Thank you, Dr. Elen. Because recent guidelines, direct us to do more, imaging guided intervention, and also, based on imaging, we use CT or CMR first before, proceeding to any kind of invasive measures. Okay. Maybe Dr. Lely have any questions for the speakers? You may go ahead to ask your questions.
Okay. Thank you. What a beautiful, nice afternoon. Yeah, we have learned from all beautiful ladies here, including Dr. Indah and three presenter and also all panelists. So I have some question to Dr. Antonia. Interesting case, Dr. Antonia. On your second case, the LAD part, you put like DES and also bioadapter stent, even it's due to insurance coverage. But what's interesting is, why did you choose put the bioadapter stent to the mid LAD? Is it regarding from the angulation or the rotational motion of the LAD itself, the anatomical position, or any other reason? And I would also like to have a comment from Dr. Deborah in this kind of lesion. And maybe all of you have read or any experience about this bioadapter technique. Is there any potential benefit related to gender? Is it female versus male? Is it any difference, or is there any other opinion about gender related into this technique? Thank you. Okay, can I answer? Yeah. So in my opinion, in the case 2, the thrombus and the culprit lesion is at the mid of the LAD. So this is the lesion that has the most severe endothelial dysfunction, and maybe the culprit of next event compared to the distal one. So distal one is only the PCI, not primary. So the primary is at the mid of the LAD. So I choose the bioadapter because the bioadapter show that it can preserve the endothelial dysfunction compared to DS. Does that answer your question?
Dr. Antonia, maybe I have a comment for this case. Dr. Lely question about that, about the mid segment that you choose to put the dynamic stent. In my opinion, it's the mid LAD is the predilection for the myocardial bridging, as we know. Whether it's let's say it's just a superficial one, not the deep myocardial bridging one without the high angulation. We frequently found this myocardial bridging, whether it's complete or incomplete. Let's say the superficial one and the coronary or the vessel fix. Maybe this dynamic is more, more
support,
adaptive, more adaptive to the to the motion of the coronary vessel.
I agree with that. And
sorry, maybe I also want to ask if there is experience about putting this dynamic stent in the myocardial bridging with lesion, let's say with significant stenosis.
Yes.
Maybe Dr. Deborah know about this.
Deborah, can you answer?
I've always thought about that concept as well, and I thought that it would be fascinating to do it, but I've not done it personally. Maybe Dr. Antonia has some experience in stenting myocardial bridging with the bioadapter.
Not yet with bioadapter, but with the older DES.
But
Yes.
I think it might be interesting to have a relook angiogram after stenting the bioadapter. I mean, maybe after 1 year or so, after more than 6 months, and once the stent uncages, to put a real-time imaging, and see how with the vessel movement, how the stent accommodates it. Yeah, I think that would be interesting. Yeah. I mean, personally for me, I've only done bioadapters on type A lesions, much less complex than what Dr. Antonio did. For type A lesions, not bifurcation, less of an overlapping stent kind of thing. It was just a one stent, did all kind of thing for now. Yeah, that's my limited experience. Yeah.
Okay, we have actually a few questions from the floor. Let me try to summarize the question first. Number one from Dr. Agung, whether elixir and the dynamic whether the dynamics bioadapter are only available in Jakarta, and whether patient with STEMI and heart failure can be cured with this type of intervention. Maybe Dr. Antonia can answer this question.
Yes, about the availability, I think we need to ask the vendor, the company. But I think it's a good thinking that we will put scaffold, or bioadapter that can preserve the endothelial dysfunction, because it's very important in STEMI patient, and also the heart failure. But heart failure is not directly benefit from the bioadapter, because one bioadapter only cure one lesion, right? Yeah, maybe it can affect later to the proximal part for development of another lesion, if compared to the kids DS. I don't know. Maybe it need later evidence about that. Thank you.
Okay, next question. I think Deborah would be perfect to answer this question. What are the advantages of using the bioadapter in patient with ACS and compared to DES stents? And I think we've answered this question prior to this. Can it reduce the incidence of ISR significantly? Maybe you can answer this question. I know you haven't put in a bioadapter in the STEMI cases before, but do you have any comment on that?
Yeah, the study that we did in hospital was for a specific group of ACS, but I think it will be very interesting to compare, ACS with non-ACS and see if there's any benefit. I'm not sure, because we have not done a head-to-head comparison. But I think in terms of acute performance of the stent, it is the same, be it non-ACS or ACS patients. The acute performance is the same, can be comparable with any second generation drug-eluting stent. But I think it's more of how in the later, how the vessel motor is, there's maybe the plaque regression, and there's less of an adverse events to conventional second generation DES. That I am not sure either. So I think in terms of whether it's only for ACS, I don't think so. I think both any lesions will benefit from bioadapters.
Yeah, can I add some more comment? Sure. So actually the RCT that I presented before, that also has presented in EuroBCR, is including the ACS, but non-STEMI, not the STEMI, non-STEMI patient. And the result show that the whole group benefit with a lower target lesion failure, 1.8 versus the 2.8, and significantly better. So but because this is the non-inferiority trial, so the evidence is for and the bioadapter is non-inferiority in ACS, including ACS STEMI patient or another subgroup. And I forgot to note that the lower lead lumen loss in overall cohort and also subgroup is whether in bioablator, the subgroup is including LED lesion, small vessel less than 2.75, and also the long lesions more than 23 millimeter compared to DS. Thank you.
Okay. I think this is a very exciting, new technology. But like anything that is new, I think we should, remember just a few years back, we've been very excited about the biovascular scaffold, which, now is a bit unheard of. So I think we should, remember that to take the new things, very cautiously when we wait for more data to present itself, and not rushing to, okay, let's all put in this new technology, in our cases. Just do it, gradually, and see the data and what comes next. And before we end the session shortly, I actually have another question for Dr. Antonia and Dr. Deborah. So after this new technology came, actually what makes the positive remodeling happens with this new technology? Can you elaborate a little bit? How does it work actually, so that us here can understand a bit more about this new technology? How does it cause the positive remodeling?
After you, Dr. Deborah.
So I think it's more like allowing the vessel to have the Glasgow phenomenon. So basically, it adapts to allowing the plaque to form, with vasodilation as a compensatory mechanism. So I think that's how it leaves the vessel uncaged so that it can have its physiological nature to compensate with plaque progression. Yeah.
And what about the safety and efficacy of this novel bioadapter when compared to actually the contemporary drug-eluting stents?
I think it basically showed non-inferiority so far, but that's on the limited group of patients. So I think we basically need a larger group to see. And I think so far, the result has been just 1 year. I think to see this benefit of this effect of preserving vasomotor function and everything, it comes at a later stage. So now we're just seeing the acute performance just like any other DES. But I think up to 2 to 3 years time, I'm not sure. So from there onwards, the data will speak for itself.
Okay. Well,
can I ask some question about the positive remodeling?
Sure.
After putting a stent, we will face two kind of situation. One is negative remodeling, and second one is positive remodeling. The negative remodeling is due to the neointimal hyperplasia, muscular type, and then the plaque behind the device. Also, like I showed it in the slide before, is the plaque is not decrease but progress. So the two kind. So and further the late lumen loss. So the three things put in total will give most of the patient negative remodeling. That mostly we found in the daily practice. But this new device, like Indah said, we're still exciting about this, but let be patient and wait for while we do as we can. Is positive remodeling because the plaque regression behind the device, 1. 2 is the lower rate of late lumen loss, and then the less neointimal hyperplasia. This is the three things why the new device has a positive adaptive remodeling.
Is there any other question from the panelists? Dr. Ati, do you want to ask another question?
I think Dr. Antonia has already explained a lot. Thank you.
Okay. Well, it's been a great afternoon. So what we have learned today is that number one, this new technology, in cardiovascular science, technology, every year we learn and we create new stuff and everything. And this new technology clearly very exciting to have a scaffold that is that can maintain the natural form of the vessel, and not as stiff as the stents that we have implanted all of these years. I think this is very exciting, but again, we need to be very judicious and very cautious about this new technology, and not all rushing to put in this new technology in our patients, but still, carefully wait for new data, and we learn from each other. And also, we must incorporate imaging in all our intervention. Not rushing to intervene every other chest pain patient, but like Dr. Astri and Dr. Elen said, in chronic stable patient, we must consider do imaging, non-invasive imaging first before we jump into the cath lab. But when the patient is in a acute condition, like stent thrombosis and everything, like Dr. Deborah says, then we have to consider to rush into the cath lab when the time is needed like that. So I think we have learned a lot from all the speakers today, Dr. Antonia, Dr. Deborah, and Dr. Astri, and from all the 4 panelists. Thank you so much for your time today. And this webinar will be recorded and uploaded to our